Good morning, everyone. So the title of my talk this morning is Calciphylaxis, also known as Calcific Uremic Arteriolopathy, a peritoneal dialysis story. And this talk was really inspired by a patient of mine who many of you may know as you've likely been participant in his care. And just to know, he is aware that he is the topic of today's conversation and is also agreeable. So before we get started with our story, I just wanted to talk a little bit about the term. So the term calciphylaxis really is considered a misnomer in that it implies a more systemic anaphylactic hypersensitivity reaction, which is not really accurate, at least in the ESRD population where we'll be focusing today. And instead, calcific uremic arteriolopathy has come to be known as kind of the more appropriate descriptive term to describe this process. However, studies involve both terms, and I'll be using both interchangeably, probably mostly calciphylaxis, as that's what I'm most familiar with. And we will be focusing mostly on the dialysis population. All right, so let's begin with our case. Mr. F. So Mr. F is a 67-year-old with end-stage renal disease, presumed to be due to diabetes, hypertension. He initially began dialysis with hemodialysis and then converted to peritoneal dialysis in 2023. More recently, he presented to the emergency department here at the VA with a right leg rash associated with some tenderness. He was diagnosed with cellulitis and prescribed Keflex and sent home. 5 days later, he was in his PCP's office with really no improvement in his symptoms, and his antibiotics were changed to doxycycline. 10 days later, he was in the ED with worsening pain. Notwithstanding, he was admitted and started on IV antibiotics, all again for the presumed cellulitis. Due to his slow improvement, ID was consulted. They agreed with the diagnosis and they continued IV antibiotics for a total of 14 days. There was some improvement in his symptoms and he was sent home. However, 10 days later, he came back to the ED here at the VA. Now with bilateral symptoms, was readmitted, started once again on IV antibiotics. And given this persistent symptomatology without any great improvement, dermatology was consulted and a biopsy was performed. Oops. So these are actual photos of my patient around the time of his biopsy. So you can see both lower extremities. The right lower extremity, where his symptoms began, was described by dermatology as an indurated violaceous plaque with wrapping around his calf to the mid shin and was considered atypical for his ultimate diagnosis. His left extremity did have 4 discrete violaceous nodules with retiform purpura. And for those of you who don't know what that is, it's a persistent, kind of dark red, purplish, hemorrhagic patches that occur on the skin and exhibit a characteristic branched configuration. And this was around his biopsy. This is the site of the former biopsy because he actually had, at least at this point, no ulceration. Here are his biopsy results, and they were described as microcalcifications within the subcutaneous fat and around deep small vessels with focal microthrombi formation. And overall, his findings were felt to be concerning and consistent with calciphylaxis. And there was actually no evidence of infection on H&E staining. A little bit more about Mr. F. In addition to his diabetes and hypertension, there is other past medical history, his medications. Of note, he's on activated vitamin D and on a ESA, oral iron. His CKD complications included hyperparathyroidism, hyperphosphatemia, and there are his labs. His most recent KT over V was a little below goal, our goal being 1.7, and this included both his PD and urine. He was still making some urine. And as you can see, his parathyroid levels were really considered at goal. So preceding diagnosis, 105, and at the time of diagnosis, PTH of 521. But the year prior, he had been less controlled. His phosphorus also had been rising prior to hospitalization around 7, and then at the time of hospitalization, he was in the 9s. Albumin dropped. hemoglobin also dropped. So when I started to look into this topic and look at some reviews, I went to a New England Journal review from 2018 and I found this quote. And I think all of us would say that this is not entirely surprising. This description of calciphylaxis as a rare, life-threatening syndrome of vascular calcification characterized by occlusions of microvessels in the subcutaneous adipose tissue and dermis that results in intensely painful ischemic skin. So that seemed to be what was happening with Mr. F. No surprise there. But what was surprising, to me, was the statements that I found in further review that patients with peritoneal dialysis, in fact, have a higher incidence of calciphylaxis than those treated with hemodialysis. And this was something that I hadn't heard of and certainly hadn't experienced. Mr. F was my first patient with peritoneal dialysis patient with calciphylaxis. And not to say that I've had many, because it is in fact rare, fortunately, but I was surprised to hear that. And also to find that mortality is felt to be higher in peritoneal dialysis patients. So I thought I needed to take a deeper dive. So I'm going to share with you my search. So today's learning objectives are to assess the data on incidence, mortality, and risk associations for calciphylaxis and ESRD, but more specifically in peritoneal dialysis, and to describe the pathogenesis of calciphylaxis as we understand it today, and then to appraise some of the quality of data on the treatment of calciphylaxis, specifically in ESRD and more so in peritoneal dialysis. So a lot of information that we have about calciphylaxis in general in all patients comes from country-based registries as well as studies that describe the natural history and outcomes of calciphylaxis. So this is an often a referenced study. It's a large study, a US study, and the largest actually that's out there, that looked at data from Fresenius, and they did a retrospective review where they matched calciphylaxis cases with non-calciphylaxis. Now these are hemodialysis patients, and they looked at baseline factors at initiation that might help identify the future risk of calciphylaxis. And I think it's important to note that the majority of these folks were their diagnosis was confirmed by skin biopsy. And as I said, they found a fair number of cases, over 1,000, and they calculated the incidence rate to be about 3.49 and 1,000 patient years. So for every 1,000 patients, about 3.49 patients had calciphylaxis. And their mortality rates were around 27% at 6 months and 45 at 12 months. And here is a odds ratio of baseline characteristics and future calciphylaxis diagnosis. And those things that stand out are a diagnosis of diabetes, nutritional vitamin D supplementation, so not activated vitamin D. Cinacalcet treatment actually was associated with calciphylaxis development, and then warfarin treatment. And I think what's surprising here is that we're not seeing so much phosphorus binders or your even serum phosphorus or serum PTH, some of the more classic risk associations. Now, this did not include any PD patients, which doesn't really help us so much with Mr. F, but keep in mind that he did begin his dialysis journey as on hemodialysis. Whoops. All right. This is another study, a registry, and another common way that people gather information. This is a German study where providers, mostly nephrology providers, registered their patients with diagnoses of calciphylaxis and recorded also baseline characteristics at the time of diagnosis, as well as lab biochemistry and therapies. So again, this is one snapshot in time, not necessarily when looking at outcomes. the diagnosis was made mostly by clinical presentation, as you can see. They found a total of 252 cases, and their estimates of incidence was actually sort of calculated based on the total number of patients on dialysis in Germany at the time. So it was much lower and likely a underrepresentation in that they likely were not capturing the total number of calciphylaxis cases through this registry. And they also were only focusing on nephrology providers, so likely missed others managed by non-nephrology providers. And because it was not followed, they didn't follow patients over time, there was no mortality data. All right. Oh, so before I go on though, so just to note, they did look at medications that were associated with calciphylaxis, and most notably were ESAs, 80%, and this was true with both PD and hemodialysis. A large percentage were on activated vitamin D, as well as phosphorus binders. And in terms of labs, really the only thing that was considered abnormal or above target was serum phosphorus. All else were at goal. This is another study, a registry out of the UK, which conducted a study, a case control study on 89 patients with calciphylaxis that were registered in this UKCS study, United Kingdom Calciphylaxis study, over a period of time from 2012 to 2020. And their outcomes were as follows. So mortality was at about 50%, just over 50%. 25% had bacteremia, mostly bacteremia coming from infected wounds. And in fact, that is the largest cause of mortality in patients with calciphylaxis, infection of the wounds and ensuing sepsis. So of note, patients with ulcers are considered to have a higher mortality. Fair number did have complete wound healing, and their median follow-up was just 5.4 or 5.8 months. And then they took all the hemodialysis patients only within their study, so they took away the PD patients and propensity matched them with a cohort, a dialysis cohort by age, gender, and dialysis vintage, and looked at outcomes. And one of the most remarkable outcomes was the association of death or decreased survival in the presence of a diagnosis of calciphylaxis. And so patients were 6.8 times more likely to die with a diagnosis. Other notable associations were older age, Caucasian race, diabetes, some of these labs. In this case, we did see parathyroid hormone having an association, ESA use, and vitamin K, once again, vitamin K agonist use. All right, so to end on some of these studies, I wanted to include a peritoneal dialysis study. This is unfortunately a single center study. What I didn't notice or mention is that the other studies did involve some amount of peritoneal dialysis patients, but very small. This was 100% of peritoneal dialysis patients. A U.S. retrospective review, again, of a single center. All diagnoses were made by skin biopsy. And they found that the incidence in their patient cohort, so 7 of their 63 patients did develop calciphylaxis, and in their estimates, the incidence was 9 per 1,000 patient years. So this is a study that is often quoted and referenced with the statement that PD is more common, or sorry, calciphylaxis is more common in PD. So it's a single center study, 7 patients. Other studies are often that are quoted with even higher incidences are such like around 4.5 per 100, or some Canadian studies, again, single center studies. So the quality of the data behind these statements of increased incidence is not great. Nonetheless, This study did find that there were some associations with the development of calciphylaxis, and again, most remarkably being warfarin therapy. Again, some similar sort of findings as the other studies, but again, each study is somewhat variable and has, discovering or identifying different risk associations. And it's hard with all of these studies to really make firm conclusions about the incidence in peritoneal dialysis patients, mostly because the larger studies don't include a lot of peritoneal dialysis patients, and the smaller studies that do are single center. Okay, so it's just a summary of the different studies, and again, I won't go into great detail in the interest of time, but you can see the different incidents here, the different mortality, again, variable. And again, the highest mortality listed in these single study peritoneal dialysis patients, studies. But again, small study, single center, so hard to know. And the risks, again, are variable. And as we all know, these characteristics are seen in probably most of our dialysis patients. So how is it that all of our patients don't have calciphylaxis? Of course, we're fortunate and happy that that's the case, but what is it that is causing patients to have calciphylaxis? Well, we don't really know or understand, as pathogenesis is felt to be uncertain. Um, as we talked about with Mr. F's histology, um, the histology analysis of patients with calciphylaxis suggests that there are calcified, narrowed microvessels that lead to initially chronic, low-grade ischemia, and with further occlusion, an endothelial injury and microthrombi result in an infarction. This is a drawing from this review in the New England Journal from 2018. And I thought it was quite nice. It represents an arteriole in the skin dermis, and this upper portion represents normal histology, where we have the normal internal the endothelium, internal elastic lamina, and then the vascular smooth muscle cells here with the elastic lamina. And then when there is exposure to some toxin, some risk, there's felt to be a transformation in these vascular smooth muscle cells where they're transdifferentiated from a normal contractile phenotype to an abnormal phenotype that's described as osteochondrogenic. And this is likely due to an imbalance of promoters that either promote or inhibit calcification. In this drawing, I won't go into great detail, but just point out that in the black are felt to be the promoters of calcification, and in red, the inhibitors. And what I would like to point out is that vitamin K deficiency or antagonism, such as warfarin use, inhibits an inhibitor. So the carboxylation of MGP, which is matrix GLA protein, inhibits downstream calcification. And if that's inhibited, there is an imbalance towards calcification and matrix mineralization. Adipocytes are also felt to influence this process by releasing VEGA, which is a calcification promoter. And this may explain why many lesions often develop in areas of higher number of adipocytes. There is then likely thrombosis, and this may be due to a prothrombotic state with or without systemic hypercoagulability. And then there's also investigation and discovery of potential genes that may inhibit the inhibitors as well and play a role in the development of calciphylaxis. So an update on Mr. F. So his management approach was as follows. We stopped his pericalcitol. We started him on cinacalcet and on sevelamer. We increased the intensity of his dialysis. He was advised to have sodium thiosulfate, which he stopped after only 4.5 doses, which we gave him at 3 times a week, the usual 25 grams IV. But he stopped due to infusion pain and to what he felt were mostly resolved lesions in his legs, which in fact they did look better. The leg pain was still there, but better. At this time, he also mentioned that he was having worsening dyspnea on exertion. An echo was obtained by his primary, which showed a drop in his EF. He was referred to cardiology. I reached out to them just to make sure that there wasn't something we should do in the interim, as his appointment was a couple months off. And they recommended goal-directed medical therapy and to wait on any further studies, despite his high risk, given his stability of symptoms. Well, his calciphylaxis symptoms worsened about a month later, or actually maybe a couple months later. And he was restarted on sodium thiosulfate, but only got 2.5 doses this time. Again, stopped to arm pain, due to arm pain. And the evening of his last infusion, he developed some hypotension and arm weakness and pain. Reed presented to our emergency department at the VA, was found to be in cardiogenic shock, was sent to Harborview where he had an urgent cath, was found to have a 90% lesion of his LAD, had a stent, and was placed on an Impella. So things are not going so great for Mr. F in many realms, and pertinent to this talk, perhaps not with his calciphylaxis. So is there any evidence to guide us from this standpoint in terms of what is best for him? So most of the data that we have about treatment efficacy in, or if not all, until more recently, is observational. And there is a variability. Some studies say there is an improvement with specific therapies, others say not. But there have been a couple meta-analyses that have looked at this, and both actually have found that there really is no improvement in treatment options. So this first study with KI looked at 5 different therapy approaches, treatment approaches. One was the use of sodium thiosulfate, another surgical parathyroidectomy, the use of calcimimetics, and then hyperbaric oxygen and as bisphosphonates, which they felt to be the most common, though I would disagree, but really found no significant clinical benefit with any of these therapies. This next one, and again, there were about 10% of patients in these reviews that were PD patients, and mostly of them were case reports. This next review was specifically on calciphylaxis IV, and again involved some peritoneal dialysis patients. Wasn't entirely clear, probably at least 16 patients out of, I think, 422, likely more, because a couple of the studies were listed to have patients who are ESRD on renal replacement therapy or on dialysis. But again, comparison of outcomes did not show any benefit. So just a little bit more about sodium thiosulfate in general. So it's an agent, again, that is unproven, but is felt to have antioxidant and maybe vasodilatory properties, and also will inhibit adipocyte calcification, again, hopefully, impacting and treating the calciphylaxis. So a little bit more, I did find this systematic rather, on PD and IV and the use of PD patients and the use of IV sodium thiosulfate. Again, these were all observational studies. They found a total of 30 patients, and it included, again, a majority of case reports. And this is just some of their outcomes data. where they broke it down by route of sodium thiosulfate. And here is the IV form, and we can see that there was still a very high incidence of death in the green, and the majority of patients actually were transitioned to hemo. There, interestingly, a fair number were had healing of their wounds. Nonetheless, this is not great quality data. And you can also see they commented on adverse effects, which didn't seem to be very high in the IV, and more so with the other forms. But some of the adverse effects that are associated with sodium thiosulfate are volume overload and hypotension, as well as some QT prolongation. So, what about better data? Well, this is a review of randomized controlled trials or rather a listing of randomized controlled trials in a relatively recent review on the topic. This was as of 2022, but I do have some updates. This first study is still recruiting. It's going to look at various interventions and compare them to placebo, so we don't have any data. This study looking at lanthanum was a phase 1 that was actually completed in 2013. No data available. This one we'll talk about in a second. This is looking at vitamin K supplementation. It is completed, but no data available. And I want to say it was completed in 2019. So who knows? This is a study that has ongoing recruitment looking at therapeutic apheresis to treat circulatory disorders, and they're hoping to wrap things up in 2027. And other studies not listed here, there have been a few randomized controlled trial attempts on sodium thiosulfate, which have been unable to get enough recruitment, so they've been terminated early. All right, so some exciting or one exciting development in this world of treatment is, in fact, a randomized controlled trial that was published just this last month, which had gone through various phases. And this is a publishing of their phase 3 study. It's called the Calcifix trial, where they investigated something called hexasodium phytate, which is an inhibitor of vascular calcification for the treatment of calcific uremic arteriolopathy. And they did an international placebo-blinded adults with randomized controlled trial in adults with calciphylaxis with ulcerated lesions, so pretty bad lesions, and they compared their intervention to placebo. And their primary outcomes were the status of the wound as well as the pain control. And unfortunately, they found no difference with their intervention. And again, this was only in hemodialysis patients. But what they did find was in their side effect analysis, there were fewer deaths and fewer calciphylaxis-related infections, as well as calciphylaxis-related hospitalizations. So some positive, potentially a positive outcome. All right. To wrap up, in summary, calciphylaxis is overall rare in ESRD, rare in general. But based on the quality of available data, it is really not clear that calciphylaxis is more common or more deadly in peritoneal dialysis. The pathogenesis is not entirely clear, but likely involves a predominance of calcification promoters, leading to calcification and ischemia. More specifically in the skin, there is this concept of visceral calciphylaxis, which we didn't get into today, but mostly in the skin. And some of the more common treatment strategies or people may use specific acute treatment strategies, but really there's no data, no high quality data to guide us, and that we must rely on our own experience and focus on eliminating more common risk associations. And I will end there.
Very good talk. Thank you, Maggie. I think we may have time for maybe one or two questions here. I'll kind of jump in. I had one question. After, going over the evidence that you mentioned there, would you still recommend treatment with, say, sodium thiosulfate, as I think we all have been, taught kind of routinely to utilize in these cases?
Yeah, I mean, um, I did,
Hmm.
that's what I did with Mr. F. I think in prior experience, really, it just depends on the particular patient. And in a hemodialysis patient that I had who had ulcerated lesions, I felt that his wound care was probably the most important aspect of his care. Um, and I think that's what helped him to survive. With Mr. F, I'm not entirely sure that sodium thiosulfate has helped him, and did it contribute to his ultimate cardiogenic shock? Who knows? Um, I'm happy to say that he is still alive and is no longer in cardiogenic shock, thank goodness. And thanks for everyone who has helped to take care of him at Harborview. I mean, I think though there's not data, just sort of working also on calcium, mineral bone disease parameters within reason. Um, Another recommendation that I'd seen kind of in the earlier reviews is that we must convert our peritoneal dialysis patients to hemodialysis. That has not borne out, and I would not recommend that. Certainly, it's easier to give sodium thiosulfate, but sodium thiosulfate has not necessarily been proven. So I think really just have to personalize the treatment and do your best, and hopefully they survive.
Wonderful, thank you. Maybe one other question or two. There's two in the chat here. So first off, from Ian Stanaway, did you come across any associations with genetic components that put patients at increased risk for calciphylaxis? As you know, it's already a fairly rare condition that we see.
Yeah. There is interest in that. I didn't look into that deeply, but there are thoughts that there are genes that are involved, and specifically sort of genes that inhibit the inhibitors. Um, so the carboxylated MPL or whatever that is. So just from that, going back to that little picture, that is certainly an area of interest with current research, but not something I explored deeply.
Great. Maybe one other question here, and then we may have to continue questions in the chat from Megan Griffin. Mentioned that she had a tough time actually finding information on how best to dose sodium thiosulfate in our PD patients, and
Hmm.
whether you do it 3 times a week like we do typically in our hemodialysis patients, or do you do it more frequently because they're dialyzing more frequently? Did you come across any guidance in regards to that?
Well, in that one review, they did dose it similarly. The 25 grams 3 times a week was kind of the predominant suggestion. There was a suggestion to give it intraperitoneally. From that review, there was, I think, actually improved outcomes. But again, the numbers were so small, and there is a high risk of peritonitis. And so I was uncomfortable with that. Um, so yeah, there's not a lot of data out there, but that one meta-analysis systematic review did suggest sort of standard dosing. Whether that's really, I mean, it's there's not a lot of data, so it's hard to say that that's right or
Sure,
wrong.
sure.
He did get better with the
Yeah.
4.5 doses, so yeah, maybe it was right. I don't know.
Well, very good. I think certainly a tough condition to manage, and thankfully, it's not something we all see very commonly. But I really appreciate your talk and helping guiding us, and if we encounter this in the future. So thank you. And
Thank
I think
you.
we have a few other questions in the chat, but we may have to continue those in the chat as we move forward with our last speaker for today.